When you combine men and women, colon cancer is the second most common cause of cancer-related death in North America. And there is about 56,000 deaths of colon cancer in 2013. This data from 2009. And there is about 136,000 new cases every year. So we lose about 1/3 of our patients every year from colon cancer. This is again from this year data, like Dr. Cody indicate, and you see the lung and bronchus is the highest mortality, and then colon comes very much second. There is a slight decrease in the mortality rate because of screening, and next slide. All right. The risk factor for colon cancer, really, there is some genetic abnormality, but the most important factor that I want everybody here to live with is family history. If one of your father, mother, brother, sister had a colon cancer, your risk is tremendously much higher than the average person. There is other risk factor, but most of the cases that we see, it is not really the familial adenomatous or the family history, it is actually sporadic cases. Next slide. Now, why colon cancer can be treated and cured, especially in demographic defined area like Guam or the Micronesian island? Because it takes about, if you look at the colon, the wall is about 3 layers, and it is almost like a factory because all the stool go through the colon, so the inside layer, the inside layer of the colon, it produces a lot of cells, so it is a machinery. And at some point, something happened and it formed what we call adenoma, or is a benign polyp. It takes years for this polyp to become cancers. And I'm gonna show you, if a colonoscopy happened at that time, and you take this adenoma out, this patient not gonna have cancer. Now, most of the adenoma stay as adenoma, stay benign, but in about 10 to 30%, depending on the study you read, they can turn into cancer. Next slide. How we screen? Of course, the rectal examination again, and the sample gets put on a paper slide to detect for blood. That's what we call, and the fecal occult blood test, sometimes you don't have to see blood to have blood in a stool. The next one is sigmoidoscopy, which looking at the first part of the colon on the left side. Sigmoidoscopy is easy, it's done without sedation, but only discover polyp in the first part of the colon. Colonoscopy, on the other hand, you look through the whole colon, and I'm going to show you a picture of that. Next slide. Okay, the colonoscopy is really the best tool we have to screen for colon cancer. Number one, it allows the physician to look for polyps and resect it before it turns into cancer. Then we have other tools if colonoscopy for some reason the patient is not prepped enough, or the colonoscopy was difficult to do on a patient. And that happens sometime when the patient has stricture in the colon. Here, when you don't have the colonoscopy, you go to the radiology department and they put barium liquid through the colon, and you are able to see it on X-ray. It is not the most optimal tool, but it is for patients that cannot have colonoscopy. Here is the sigmoidoscopy. It can be done in an office setting, and you're looking into the first part, or the lower left part of the colon. It's done without sedation. is definitely much more comfortable than having colonoscopy, and because about 30% of colon cancer happen in that left section, but that's changing. When you look at the data from 10 years ago, you find it was on the left, now it is on the right, so we're not really sure. And next slide. Now here is the colonoscopy. After you get, of course, prepped, which to clean the bowel, and you get sedated. It happened in the OR, and allow the surgeon or the gastroenterologist to advance the scope, look through the whole colon, and he find any polyp, he can resect them. Next slide. Now there is a new technique, doesn't work that well yet, but my personal prediction that this is going to be the way to go, which is a capsule, has a camera in it, you swallow it like a pill, and it takes a picture of the colon, and then you can see it on a computer. Next slide. Now, from the polyp that was benign, that's what cancer looks like. It starts in the inner wall of the colon, and it starts to invade to outside as it grows also on the inside. So, what the patient would feel? Well, if you start having symptoms, it's probably too late. Because most of the time, if you're lucky, if you imagine the residual part of the food that go through the colon, on the right side, it is liquidy, it's slushy. So even if you have a lesion, it's not going to cause any bleeding. And if you have a lesion, the bleeding is not going to appear when you have a bowel movement. But if it is on the left side, you may see blood when you go to the bathroom. Now, sometimes you don't see blood at all, but you go to your doctor, you do a CBC, and you find that you have anemia. I mean, you're losing blood, but you just don't know it. Once anemia starts, you start feeling weak. If you start having weight loss, that means the cancer has gone to your liver, and it becomes stage 4. If you start feeling mass in the abdomen, that is really too late. Now, you remember I showed you the picture, the liver over the right side of the colon. Where the cancer of the colon goes when it metastasizes? In the liver. They share the same blood supply, and it goes through the blood and also adjacent to it. Rarely it goes to the lungs, but most of the time, the liver is the first site that colon cancer goes to. Of course, cancer can behave differently, and every now and then, you have colon cancer that goes to the brain, but that's not really most of the time. Okay. Also, if the cancer undetected, and as I said, if you imagine the colon as a large hose, it starts inside and goes out. What's out the colon is the peritoneal cavity, and you have the bladder, and if you're a woman, you have ovaries, and they can go to all these places if you wait on it. Okay, next slide. Here is what I want to show you. There is a module that was done. What will make adenoma or benign polyp change into cancer? Well, think about it this way. Every cell has genes, and the reason that the polyp starts because one cell has mutation in the genes and starts multiplying on its own, forming a mass. There was a module called double hit. That means this polyp, to become cancer, it needs another genetic mutation. And the module has shown that it takes 5 to 12 years for a benign polyp to become a cancer. So if we follow the recommendation, having colonoscopy at age 50 and remove the polyp, it's going to be every 10 years, and nobody should have. And when I mean nobody, you can prevent it up to 90%, especially with a demographically defined area like Guam. If you wait a little longer, it start to spread outside. So stage 0, it is still only on the inner wall. Stage 0, even if cancer at this point is curable in 100%. Stage 1, it goes through some of the layer inside. If it's detected at a stage 1, the cure rate more than 95%. Once it goes to stage 2, the numbers start to drop. Stage 2, if it's detected, that means it went through the walls but did not extend on the outside. Cure rate at this point is 85% by surgery alone, no chemotherapy. The problem happens when it becomes stage 3. That's when we get involved. That's when it goes to the lymph node outside. It went through the walls and extend outside to the fat around the colon, and then we collect the lymph node and we check it under the microscope. Here at this point, surgery alone will cure 65. That means 35% of every patient is gonna die as a result of this if we don't do anything else. And this is the stage that we give chemotherapy. And it's extensive, and it costs us about $8 billion a year, and the patient go through 12 cycles, and it has a lot of side effects, and a lot of people cannot tolerate it. So that's when we start having problem. Stage 4, the last one on the right, it went outside, it went to the lymph node, and also was detected in the liver or the lung. And that's incurable for the sake of, of discussion for now. Okay, as I said, stage 1 or T1, that goes by the size, and if it went to the lymph node, I don't think that's important. The important thing is you want to detect it before it happened, and if it happened, you want to detect it early. Next slide. Okay, the doctor found that you have cancer, and the surgeon goes in, where, which part, and they do a surgery called hemicolectomy. He cancer in the middle, he takes large part of the colon to make sure that he has enough free margin, then connect your colon together. It's very easy surgery in an expert hand. It is done now also by scope. You don't have to even open the patient. And the recovery time, probably in the hospital about a few days, and then the patient comes to us afterward to look at what stage. If this patient comes to me, the first thing I look at is the pathology report. What stage? If it's stage 1, tell him congratulations, and go and keep with the colonoscopy. Stage 2, we'll start to look at him closely, because stage 2, remember, 85% only cured, so 15 out of every 100 gonna come back with a stage 4. Stage 3, they get the chemotherapy treatment. Stage 4, they're gonna be on treatment for life, and they're gonna die as a result of colon cancer. Where to go from here? And MD Anderson had a module one time of having cancer prevention clinic, and it was great. They identify people at high risk, and it's done once a month. And if somebody at high risk, they screen them, and they suggested the colonoscopy, and MD Anderson had the muscle to cooperate with everybody and to do the colonoscopy, mammography, whatever. But it didn't work, or not didn't work. It may have worked, but the data to support it wasn't there, because MD Anderson drew from everywhere. You take that module and you apply it to Guam. And a young lady asked how you educate the public. It's gonna take hospitals, doctors, schools, insurance company, surgeon, nurses, oncologists, town meeting in every area. Like Dr. Cody said, monthly, and you choose a specific months, you talk to the children from young age, and in Guam, you can prevent colon cancer up to 90%. Up to 90%. Imagine what an impact that would be. It happened, and I have started cancer center in a smaller area, and I found it doable with the cooperation of everybody, everybody in demographic, defined area. Thank you very much.
Thank you very much, Dr. Behairy. We'll now open the floor for any questions. I'll start off. I have a question for you, sir. You mentioned that with colon cancer, the hereditary, the line of family does play a role in that. Now, when you talk family, are you meaning everybody in the family? My grandfather passed from colon cancer. My first cousin passed. Am I at higher risk like that? What are you thinking?
The risk is related to how close the person and how many in the family. And your risk, it doesn't necessarily that as a son or grandson that you're going to have a colon cancer, but your risk is 100 times more of somebody else your age. And your risk when there is a strong family history, and if your father had the colon cancer at the age of 50, you don't get the colonoscopy. If you're going to get the cancer, it is usually 10 years younger than the stated age. Remember, it takes 5 to 12 years for cancer to develop, but it doesn't take long at all to become stage 4. So people with the stage 1, 2, and 3 may have absolutely no symptoms. So don't wait for symptoms. It is not like you're going to find a lump in your breast. And if you listen to the speaker before, they were talking about screening to find cancer earlier. Here in colon cancer, you can screen to cure it and terminate it as cancer.
All right, there you go. Any other questions from the crowd here?
I once heard a comparison between the anatomical differences between carnivores and omnivores. And for the benefit of the audience, not that you don't know this, there are 3 categories: carnivores, omnivores, and herbivores. Can you not hear me? Carnivores eat meat, strictly. Omnivores, like us, Homo sapiens, eat a combination of meat and vegetables. Herbivores, strictly vegetables. So the comparison was between the intestinal tract length between carnivores and omnivores.
You're talking about the length?
The length of the intestinal tract in its entirety. And the reason, perhaps, that carnivores don't necessarily have colon cancer is because the meat that they eat doesn't sit very long in the colon before it gets passed right out because of the shorter tract length. Whereas with omnivores, us, it sits for a while in the colon, and as a result, may be sending the signal to the pituitary and then on to the adrenals to increase the testosterone levels, which in turn causes other problems. Raises the acidity levels in the human body, may cause certain types of cancers like colon, prostate, and other anomalies like osteoporosis. Could there be any truth to that theory?
Well, the merit of the question cannot be answered because to measure the length of the small intestine, that means you have to open somebody who eats vegetable or somebody who eats meat to find out the difference in length. All we know that human small intestine is about 6 feet, the colon is about 180 centimeters, but I'm not very aware of the length, and I'm not aware of how you're going to compare the length without opening the patients, and who's going to submit or do such a study. So.
All right. Sir.
Doctor, I had a stomach problem about 3 years ago, and I have colonoscopy twice, and the result was the doctor said there's no problem except they found a small polyp and they remove it right away. And then last week I was bleeding a little bit again, And I feel like I'm afraid of to go see a doctor again because like this year alone, I had 2 surgery, and then plus, all those blood tests. And I'm having a phobia now going back and forth to the doctor or the hospital. Is there any other doctor where I can see that? Because I feel like every time I go there, they're going to say, you have no problem.
Okay.
What's your take on that? Thank you.
Having polyps in the colon, there is as I said, there is a familial pulposis issue that family, but very rare, that a person have a tendency to develop polyps much more frequent and much more in numbers than anybody else. Having a polyp at the stool, especially if the stool getting solid on the left side, and they scratch the polyp, it breaks some blood vessels, and that's probably what you're seeing. If the doctor did your colonoscopy and removed the polyps, and apparently he didn't have a reason to think that you are one of those people that tend to form polyps and larger number and more frequently. And he did the colonoscopy recently. You have to look for other sources of bleeding. Most likely you're going to have another scope, because if it is coming from the colon, it has to be either from the colon or the rectum, or if some people have, it's not a blood disorder, it's blood vessel disorder, that it can be anywhere in the body. It could be in the bladder, and every now and then it happens sporadically that your urine is red, or it can happen in the colon. You look too young to me to have diverticulosis. So my recommendation to you, don't have the phobia from the doctor. If you're not pleased with yours, go to somebody else. Dr. Corey indicated that what we really do in oncology is I try to have my patients on the first visit understand what I do at the moment in a language that they understand it, and give them a roadmap is what to expect. And because the answer when the patient comes, I know the pathology report, I know what they have, I know what is the plan, that's not going to take long. But to have the patient walk the walk, you have to walk it with them. And to have the patient convinced, they have to understand how serious the condition as you understand it as a physician. And I think everyone should demand, before they leave their doctor's office, that they understand the issue exactly like he or she does.
All right, there you go. Walk the walk, you got to walk it with them. I like that, sister, just like footprints. All right, nobody else read footprints. Anybody else have any other questions?
Hi, good morning, doctor, or good afternoon. My question is, for those people that are lactose intolerant, that would resort to maybe taking particularly an Imodium, mostly every day. My question is there a side effect to our digestive system or our colon in the future? And what are the, how do you call it? Yeah, the options.
Okay.
Thank you.
Lactose intolerance was discovered a long time ago. And if lactose intolerance patient was a high risk, it would have been detected. And I'm going to generalize the food in general, not specifically. Every data was taken on different kind of food. People that eat fruit and vegetables, people that eat meat. Every data came conflicting to the point you can take it as a general rule, just eat healthy. There is no food that's going to protect you from cancer. Cancer itself is really is not a right term. Cancer was the name the Greek gave it because they found people having masses when they die and infiltrating everywhere. And when you look at the word, any human, when you have something that is foreign and growing, and the word means crabs, actually, you know, like, and as we're learning now that not all cancer are the same. So when somebody comes and say, are they going to find cure for cancer? Which one? Which one? Which organ? I can have 10 patients with breast cancer having the same size, same grade, same data that we collect on everybody, same number of lymph nodes, getting the same treatment. 6, on them it works, 4 doesn't. Mayo now, they found out that, and the previous speaker talked about BRCA1 and BRCA2, the 2 genes that we found in breast cancer, and everybody hung the hat on them, is still didn't work. Yes, we detected more family that have the genes, but now they have genetic panel that is 22 different mutation.
Wow. And
it is not available for us yet to use, but they develop all the new treatment based on that. That's why we call it target therapy. You have this mutation, they form something to go ping, rather than chemotherapy. When I left the university in 1996, all we did, 99.9% is all chemotherapy because it's a growth, treat it, and we give it poison, and you hope for the best. Ask Dr. Chowdhury or ask Dr. Cody how much chemotherapy we use now. Way much less than 40%. Most of what we use is target therapy, biological therapy, based on this genetic information that we gain every day. And we're still at the surface. So cancer is not, collectively, it is not one disease.
All right. And then the second part of her question was about Imodium. I guess like Imodium AD or whatever is there any side effects, or will that affect the colon health as far as taking Imodium or maybe other medicines such as that on a daily basis?
Well, you have to ask yourself why you have to take Imodium on a daily basis. That means that you having chronic diarrhea and that need to be addressed.
So go to the root of the, maybe if you're, like you mentioned, lactose intolerant, scale back, right?
Here is just to, most of adults, as they get a little older, and I don't mean it they start to worry at their bowel movement and actually constipation, not diarrhea. But if somebody has chronic diarrhea, if it is related to the lactose intolerance, that's understandable. But if it is not, and somebody has diarrhea, it needs to be worked out.
Okay. Ladies and gentlemen, please one more time, give it up for Dr. Ahmed Behairy from the Guam Regional Medical City. Thank you so much, sir.